Okay, I've started the meeting. Right now, nobody is hopping on.
Is there a sense of how many people you'd like in the meeting before I get started?
You could get started. I'm surprised nobody's in yet. Yeah, and I'm not getting any questions. Only one person reached out asking for the link, which I pointed them in the right direction, but that was one person. I'm really surprised nobody has signed on. Let's see. I'm getting a few more people that they said they're not getting the link to register.
Huh.
Interesting.
Well, no worries from my end. I think, I'm not even sure I would take the full 90 minutes, so it's not,
Okay.
I don't feel rushed. Yeah.
Okay. Heather, are you on?
Yeah.
So they're saying, I don't know if you heard me, but folks are saying they're not getting the link after they register.
Interesting.
Yeah, there's no link being. Everybody's saying that. There was no link to join.
I know why.
Why?
Because the former person used to have to go in and give their approval for each individual, remember?
Oh. Okay. Can you do that? And I'll
I
answer
can't,
this.
I don't have access to that. She's the organizer.
Oh my God.
Yeah, I just thought about that.
Dang.
So
That creates a problem.
yeah, here's what we're gonna do.
You have a workaround. I am so sorry about this. We just recently lost the person who set this up. And we were told that it was functioning as it always does. But we aren't apparently in the right, given the same permissions that we need to be, the permissions we need to move forward. So let me send something. Okay, we have rectified, Heather's rectified that problem, so give
Great.
folks a few
Yeah.
minutes to get on board, and then we'll go from there.
No worries. Yep.
How do you pronounce your last name, Doctor?
Shaliro.
Shalira. Thank you. Okay, we have like almost 20 people on now,
Oh, great.
but they're coming in fast and furious, so.
Okay.
Okay, we have about 43 people on, and we're going to continue to get a few more coming in, I'm sure. But why don't I introduce, well, I'm going to have Dr. Schlera introduce herself, but welcome.
Okay, thank you so much. I'm not able to actually see the faces of the people that are here, but I hope you guys can see me, and I certainly hope that you can see my slides. So I'm so happy to be here today with you. My name is Denise Shaliro. I work at the Yukon Waterbury Hospital. We actually just changed our hospital name as of March 1st. We joined the Yukon Health Network. And I'm an internal medicine doctor. I do most of my clinical work in the inpatient setting, taking care of patients that get admitted to the hospital. And I do a little bit of work in the outpatient setting, and that's where I focus on the internal medicine treatment of substance use disorders. And the other aspect of my job is that I'm the program director for our internal medicine residency program. Here at UConn Waterbury, we have a 36-person residency program, and so I dedicate a lot of my time to teaching. So I'm so happy to join you here today to talk about an area of interest that I've had for a very long time within internal medicine, which is the medical treatment of substance use disorders. And I realize that, you know, the audience that I'm speaking to today, that you all do this for a living. And I want to make it clear that I don't pretend to be an expert in this area, and certainly not any more expert than you all are. But for me, it's been a real area of interest that I've had, because I've seen, you know, how much the community sort of needs access to substance use disorder treatment and how it affects lives. So I started to learn more about it about a decade ago. And for the last 10 years, I've been treating patients mainly with opioid use disorder in the clinic that we work at across the street from the hospital. So, you know, really what I intend for the talk to be today is hopefully more of a discussion, because I would imagine that you all have, you know, a lot of knowledge of this area already, and may have some things that you would want to share in addition to what I'm going to bring up and talk about. So it'd be wonderful if we could have a great discussion about the area that we both work in. So that's sort of my introduction to the topic. I don't have any disclosures, and I am not an addiction medicine physician. I didn't do a fellowship in addiction medicine. I want to make it clear that I'm an internal medicine doctor who does both inpatient medicine and primary care. And we work really hard to try to teach our residents how to approach the patient that has a substance use disorder. So my hope, you know, for this talk is that we'll review some things that you're probably all very familiar with and then have a discussion. So the approach to the care of a patient with an opioid use disorder, medications for opioid use disorder, as well as I have a little bit at the end that talks about pharmacotherapies that I've been seeing and sometimes using for other substance use disorders, to really just recognize the complexities of this patient population and some comorbidities that might present challenges to care. And then I don't think you could really discuss substance use disorder and the treatments without touching on harm reduction and how it applies to the care of our patients. And I would just say that while we'll leave time for questions at the end, please don't hesitate to unmute your screen, unmute yourself, and just chime in, ask questions, make comments really throughout the talk. So I wanted to present a patient, so I'm kind of approaching this from the internist perspective. I know that you're at a substance use outpatient, you know, rehab program, and so your approach might be a little bit different than the internist, and I think it'd be really interesting to compare and contrast. But this case that I want to present to you all is based on a patient who had come to our clinic, and I'd like to use it to sort of anchor the discussion that we'll have over the course of the next hour. So this is someone who I recently saw. A 53-year-old man with an opioid use disorder returns to clinic asking to be restarted on buprenorphine-naloxone or Suboxone. His history of his present illness was 35 years ago. At the age of 18, his opioid use disorder started, and it had started with IV heroin use, and more recently it's been IV fentanyl. He had a 4-year period of remission while enrolled in a methadone maintenance program. And then unfortunately, about 10 years ago, he relapsed. And he's been pretty regularly using 4 to 5 bags of fentanyl intravenously daily. He tells us that he uses sterile, one-time use needles, bottled water, and he never shares his needles. He also uses inhaled cocaine 2 to 3 times a week for many years. He has an active tobacco use and occasionally uses cannabis. His opioid use disorder was complicated by hepatitis C that was successfully treated some years ago, and Staph aureus tricuspid valve infective endocarditis that was treated 6 years ago. And he's struggled with recurrent skin and soft tissue infections in his arms at the sites where he injects. He's had 3 to 4 unintentional opiate overdose episodes in the past, and sometimes he's had to come to the ER, but many times his sibling has administered intranasal Narcan with good effect. He's motivated to quit opiate use as he sees the negative impact that it's having on his life. And he'd taken Suboxone from friends, being given to it, not prescribed it. And he's asking to start or restart it. And he tells us that his last injection drug use was the morning of the office visit. And again, please, any questions, please just chime in. He mentions that he's had some weight loss over the last year. He doesn't feel like he feels his clothing is fitting looser on him, but he can't give us a objective number of pounds that he lost. Denies fevers, chills, cough, chest discomfort, palpitations, abdominal discomfort, nausea, vomiting, diarrhea, constipation, dysuria, leg swelling, or any kind of rashes or skin lesions. His past medical history is, as I said, and he also notes anxiety with intermittent panic attacks. Never been treated, never been seen by a behavioral health specialist, but he sort of notes some traumas that he had as a child and in his life and feels that he might have post-traumatic stress disorder. He had an appendectomy as a child and a mother and a sibling with diabetes. He was born and raised in Connecticut. He graduated from high school. He's divorced with 2 adult sons, and he's estranged from his ex-wife and sons. Lives with his brother, who's a good source of support and is aware of his struggle with substance use. He's worked in construction and he's been unemployed for the last couple of years. Not sexually active in the last 5 or 6 years. He did have prior sexual activity with women, used barrier protection, and he denies a history of sexually transmitted illnesses. And I told you about his substance use history. He denies alcohol use. No medications, occasionally uses some over-the-counter Tylenol, acetaminophen, and ibuprofen. Doesn't have any allergies. When you meet him, he's thin, calm appearing, middle-aged man, fluent speech, appropriate affect. He's conversing appropriately without difficulty. His vital signs look okay. You do see that he's lost weight, about 10 pounds from the last time he was in your clinic a year and a half ago. The things I'd point out on his physical exam, he didn't have murmurs, his lungs were clear, he didn't have any stigmata of liver disease, no swelling, no joint swelling. He had some scattered, like sort of track marks, scattered areas of hyperpigmentation and skin thickening in the bilateral arms at prior injection sites, but no evidence of infection in those areas. And he was walking with a steady gait, alert-oriented, no focal neurologic deficits. Pertinent labs that we were able to get that same day were urine drug screen positive for cocaine and fentanyl. No significant abnormalities on his blood counts or his electrolyte panel. His HIV antibody was negative. His hepatitis C antibody was positive, but the PCR was negative, and he was hepatitis B immune. This is a recent EKG. We always like to try to get them in the clinic just to kind of get a baseline and to look at the QT interval. So that this is an example of a normal EKG. So to try to start off the discussion, I wonder from your perspective, and I know that you see patients maybe similar to this. What do you think that you would be doing, kind of meeting him and having this information about this patient in terms of what your next steps would be? Open up the chat if you want to type in or just unmute.
Please feel free to go up to Q&A and answer any of the questions through there, or raise your hand by clicking on the raise your hand icon. That's what you would call it, up at the top of the screen, and I could let you in. Okay, we got one question. And no.
I know that there's different types of healthcare professionals in this audience. And so really you could answer the question from your perspective in terms of what role on the healthcare team you have. It doesn't have to be even all clinical, in terms of what medication you'd prescribe. Really just, if you have this patient sitting and kind of asking for this kind of help, how you might approach it. Because what I'll share with you is how we approach it in internal medicine. And I'm curious to know how you would.
Feel free to chime in, you guys.
And if not, I can move on if you're just thinking about this as we talk. I'll give it another 30 seconds or so.
We have one comment. Hold
Okay.
on just a moment. Anna says, I feel like getting his mental health addressed would be the first thing to do to address his anxiety, in which may be triggering to his use.
Yeah. I think, Anna, I think that's, yeah, yeah, exactly. And I'd love to talk about that a little bit more in terms of, you know, he mentioned he thinks he has anxiety, struggles with panic. He has past traumas and really hasn't seen anybody for that. And I think you're right. We can prescribe any number of medications for his opioid use disorder, but without getting at the root of it, we're probably not going to have, total success, which is to try to put him into remission with his opioid use disorder. So thank you for that. Okay.
Thanks, Anna.
I'm going to move on here. So I don't know that this is new information for anyone here, but I always like to kind of, in my mind, when I'm seeing a patient with an opioid use disorder, to, classify it as mild, moderate, or severe by quickly going through the DSM-5 criteria. And it's broken up into, do patients meet the criteria for impaired control, opioids used in larger amounts or for a longer period than intended, unsuccessful efforts or desire to cut back or control use, excessive amount of time spent obtaining, using, or recovering from the opioids, and of course, cravings. So that's the impaired control. And then the social impairment, not being able to fulfill major role obligations at work, school, home. And this patient certainly said he wasn't able to work, and he's had family estrangement because of this. Persistent or recurrent social or interpersonal problems that are exacerbated by opioids or continued use. Reduced or given up important social, occupational, or recreational activities. Risky use, using it in physically hazardous situations, and then continued use despite knowing that it's harmful physically. And this patient certainly had overdose. And then pharmacologic, so tolerance and withdrawal. So based on the number of sort of bullet points that person has, you put mild for 2 to 3, moderate for 4 to 5, or severe for 6 or more. And I think this patient probably, qualifies for a severe opioid use disorder.
Can I just chime in?
Yes.
Can I interrupt for 1 second? Vanessa also had a comment on your previous question and
Please.
said that discuss plans for sobriety if there are plans for it. Goals to achieve regarding treatment and or life goals.
Wonderful. Thank you so much, Vanessa. I don't know what you have at your practice. In my office, we have this sort of like an intake form. And one of the first questions is, what do you hope to get back to? What are your goals for, your treatment? And I always find it so fascinating what people would say. For some people, it's, I want to, improve my relationship with my family. And there's a son that I haven't talked to in 10 years. For some, it's, I'm having financial trouble and I want to be able to afford things again. For some, it's getting back to work. So I think it's always really great to establish that off the bat. And then, over the course of treatment, then be able to kind of go back to it. Are we getting to your goals? Is it working? So thank you for that. I'm not sure. I try to look at these numbers every year or two just to kind of see. So the latest data that I could find were from 2023. They usually come out like what they come out for the 2 years before. So in 2023, there were about 105,000 drug overdose deaths, and most of them, about 80,000, were opioid overdose deaths. And it's estimated that 5.7 million Americans have an opioid use disorder. And drug overdose is a leading cause of death for ages 18 to 44. So these numbers always impress me in terms of just the sheer number. This I always find this is useful for me. It's from the CDC database, and it kind of can break things down. So this is the total overdose deaths by sex, so it breaks it down into female in orange and the male in yellow. And you can see, like we said, 105 overdose deaths in 2023, and it went down a little bit from 2022. Can anybody, do you guys know, you see 2021, between 2020 and 2021, the numbers really spiked. Do you guys have a sense of why that happened or why we think that happened in 2020 and 2021? What was going on in the country and the world at that time? Um, what do you, Heather? Sorry, I don't know how to answer that here. Did you answer? Do you want to put it in the chat or speak?
During 20 and 21, I would assume because of the pandemic, there
Yeah.
was also an increase in alcohol use around that time too. And then we
Yeah,
have
that's
a bunch of other comments, I believe. Pandemic,
Yep.
everybody's going to COVID and depression. Yep.
Yep, that's exactly it, right? I mean, you know, we know that, right? Like, you know, around that time, alcohol use increased, substance use increased with that. People were isolated by virtue of what was going on with the pandemic. There was a much less access to care. I don't know about you guys, but for a good period of time in our primary care clinic, we went totally virtual. And I think I learned during that time that virtual it's good, it's better than nothing, but it's not as good as those face-to-face kind of in-person visits. So so a lot of people fell off to access to care and just the social isolation and access to drugs and alcohol, I think led to that spike. So those are the numbers for total overdose deaths. And then if you kind of break it down a little bit by drugs and drug categories, so you could see by far and away, right, is this gray where it's synthetic opioids other than methadone and primarily IMF. And that stands for probably what you know, illicitly manufactured fentanyl. And so, you know, we know that the majority of the drug supply that's on the street now is not heroin, it's fentanyl or other drugs that are mixed with fentanyl. And I don't know about you all, but in my practice and in the hospital where I work, many times people come in and it's very clear they've had an overdose or intoxication. And when we check their urine drug screen, you know, the UDS8, it's totally negative, and it's negative for opiates. And then when you check the urine fentanyl, that's what's positive. So, you know, that tells me that what people are taking is not heroin, it's fentanyl. And you can see that that's really where the majority of the overdose deaths are coming from. And then, of course, you can see in yellow psychostimulants, primarily methamphetamine. Cocaine is on the rise over the last several years. And then you have other drugs like prescription opioids, benzos, heroin, and antidepressants that are a little bit lower. Overdose deaths involving any opioid by sex. So you can see that number that I gave you, 79,000 in 2023, and more men than women. And then overdose deaths involving prescription opioids, which had been more of a problem in the early 2010s. It looks as though that's on the decline. You can see that for both men and women, those numbers are on the decline, and that was 13,000 in 2023. And then what's really on the decline too is overdose deaths involving heroin, because it's more going to be the fentanyl. And so if you can see also that heroin in combination with synthetic opioids like fentanyl is much higher than just heroin without any other opioid. And I think, in my mind, I think that just has to do with the supply and what's actually being sold on the street. Only one or two or more of these. So overdose deaths involving stimulants, so cocaine. And what you can see is that stimulants without any opioid kind of has flatlined, but in yellow here, stimulants in combination with synthetic opioids is the thing that's on the rise. And what I always like to sort of talk to my patients about are, you know, are they using both cocaine and they know that they're also using, you know, fentanyl, or do they think that they're just using cocaine, but that cocaine is laced with fentanyl and they don't know it, because that's really, really dangerous. And so a lot of the counseling revolves around, you know, you don't know what you're getting, and you have to be very mindful of what you're putting in your body. So those are just some of the numbers. I know that's a little dry, but it always helps to reorient me to know, you know, what are people actually dying from and what do we have to be on the lookout for? The next thing is really just where are we at with accessing care for opioid use disorder? You know, you're obviously, you know, in a position where you're like the heroes of the community because you're working in a center that provides this care. In 2022, it was estimated that about 3.7% of US adults needed opioid use disorder treatment. And among those, only about 25% actually received medication for opioid use disorder. So you can see how they broke it down in this chart here. So about 9 million adults needed the opioid use disorder treatment, and about 55% received some form of treatment, and the other half didn't. And they didn't because many didn't perceive that they needed opioid use disorder treatment. And then, far less perceived that they needed treatment, but just didn't get it. And then for those that did get opioid use disorder treatment, 30% received it, but it wasn't medication. So maybe it was in the form of cognitive behavioral or, counseling. And then 25% actually received medication. So it's just sort of interesting to think about, what are the barriers to people getting care at all? And then what are the barriers potentially to people getting medication for opioid use disorder? So, again, to try to make this interactive, I wonder from the group, what do you guys think limits access to medications for opioid use disorder? Why is it just 25%? Why is it not more than that?
Okay, here we go. Homelessness, financial responsibilities.
Yep. Yeah, I would agree. I think, often a substance use disorder is just part of what complicates someone's lives, like psychosocial, financial, right? Those things can be really, really complicated. Do you think that there's anything from our end, like the healthcare professional end of things, that might be a part of limiting access for patients to get medication?
Stigma, lack of awareness, education, location, insurance,
Yeah, yeah,
transportation, insurance cost, especially going forward.
absolutely, absolutely, yeah. So that's a lot of what I have here in my slide. Okay, so some clinicians prefer the approach that doesn't include medications. Methadone for opioid use disorder, as you probably are aware, can only be dispensed from a Substance Abuse and Mental Health Services Administration certified opioid treatment program, or an OTP. So for me, for instance, working in primary care, my center is not certified to provide methadone as treatment. We can, of course, give naltrexone and Suboxone, but I can't give methadone for treatment for opioid use disorder. And as you probably know, and I think was mentioned, not every county, not every place in the world has good, close access to these OTPs. Sometimes people have to drive an hour and a half, and that's very hard for people who are trying to carry jobs and pay their bills and things like that. So that might be a limitation. And then buprenorphine or naltrexone can be prescribed in any setting, but it's always amazing how many facilities just don't offer them. Some facilities that don't accept clients using medications for opioid use disorder. Some pharmacies don't stock it. Some insurance restrictions that require prior authorization that could delay it. And then the data that I had from this article from 2024 is that less than 10% of physicians obtained the waiver that until 2023 was required to prescribe buprenorphine for opioid use disorder. And when they sort of surveyed them as to see, well, why didn't they get the waiver? Some cited too little experience treating opioid use disorder, concern about being inundated with requests for buprenorphine, and then a lack of access to addiction or behavioral health specialists. So I think it was a real barrier. When I got my waiver, it was 2015, I think. At that time, you had to, if you're a primary care doc like me, you had to do about an 8-hour online training program. And then once you did that training, you took an exam. And if you passed the exam, you can apply for this waiver. It was like a special number on your DEA that allowed you to prescribe. And so that was the less than 10% of physicians that went ahead and did this. The good news, as you might know, is that as of 2023, they took away that obligation for physicians to get the waiver. And now anyone with a DEA can prescribe, and that includes MDs, DOs, PAs, NPs. So the goal was to try to increase that number to way more than 10% of providers. But there is a discomfort among some people because they're not too familiar and comfortable doing it. Okay, so I'm not going to have you answer this question. In terms of options to treat opioid use disorder, I'd like to kind of segue into that. And I know that you're exposed to this every day with what you do. So to me, I break it down into detoxification, which is using medications to decrease the withdrawal-related discomfort and complications. And any patient that I've ever treated, and I try to ask, what's it like to withdraw? They say it's absolutely horrific experience. So it's trying to help people kind of come off of their opiate by, giving them medications to help them with those symptoms. And then once you have them successfully withdraw, then you try to maintain an opioid-free state. And then the other option is detoxification followed by maintenance therapy. And the 3 FDA-approved medications are methadone, buprenorphine, and naltrexone. And we'll talk, a little bit more about those 3. So, we try to have evidence for the things that we're doing. And when you look at, if you're just going to do detoxification followed by maintenance of a non-opioid state, what we know is that, we can control people's symptoms and we can help them successfully withdraw. But unfortunately, after you get people to an opioid-free state, the relapse rates are quite high. And so, in my practice, we try to help to get people, on a medication, unless there's a real contraindication to doing so. This was an old study from about 25 years ago where they looked at methadone and they compared it to about a 6-month psychosocially enriched detox treatment program for opioid dependence. So it was basically methadone maintenance versus, withdrawal followed by being on, no medications. And what it showed was that a methadone maintenance program, or methadone maintenance therapy, resulted in greater treatment retention and lower heroin use rates than just doing the detoxification. And the methadone maintenance treatment had a lower rate of drug-related risky behaviors. But I think it's important to point out that in both groups, monthly heroin use was still quite high. It was still 50% or greater. So it's, we're fooling ourselves if we think that these medications alone are going to be 100% effective. But what this study showed was that the days of use per month dropped markedly in people that were on a methadone maintenance treatment program. So what is methadone? It's a synthetic opioid. It's an old medication developed in the 1930s. It's a full opioid agonist, and it has slow metabolism, very high fat solubility, and it's longer lasting. So if in my practice, sometimes people want to go from being on methadone to Suboxone, and it's really tricky for reasons that we'll talk about later, because you have to wait until methadone is kind of out of your system to start Suboxone, and it can be really variable how long it takes for methadone to sort of get out of your system, because it can be long lasting. And then, of course, buprenorphine is a partial opioid agonist, right? So it's weaker than methadone. It also has a long half-life, and it binds very tightly to the opioid receptors versus methadone and heroin and, say, oxycodone that are weak binders but are full agonists. It's been approved since 2002, so it's a newer medication compared to methadone. And because buprenorphine does have the potential for abuse or overdose if it's injected, that's why the manufacturers added naloxone, thus creating Suboxone. So naloxone is an opioid antagonist, and it doesn't really have any bioavailability if you just put it under your tongue, but it has good absorption if it's injected. And so it protects people if they're going to inject it from having overdose. I hope that makes sense. And if it doesn't, please just ask. And this is sort of what I said before. So the waiver elimination, it was called the Omnibus Bill, and that was in 2023. And it removed the federal requirement for practitioners to have a waiver to prescribe buprenorphine for the treatment. So all practitioners with current DEA registration can prescribe if permitted by applicable state law. And I know in Connecticut, anyone with that DEA registration can prescribe. And that really is very helpful, I think. And then naltrexone is also FDA approved. And as we know, that's an opioid receptor antagonist. And it simply blocks the effects of opioids, and it prevents intoxication and physiologic dependence. So I'd like to ask if anyone would want to offer in the chat or unmute. Why would a patient or a practitioner choose one versus the other? Why methadone versus Suboxone?
Well, we're waiting for responses on that, Dr. Schlera. Rachel asked a question of you saying, from your expertise, how long do you think patients can stay on MMT? Some patients are worried of being on MMT for life, especially given how hard methadone is to get off of. You
Yeah,
should be tapered slowly.
Yep. So great question. And again, I don't prescribe methadone because I'm not an addiction medicine specialist, and I don't work at an OTP. I get that question a lot for Suboxone. My residents will ask, well, you have this patient on Suboxone. What's the end point? When are they going to get off of it? And I think the answer that I have is, it has to be patient centered, right? So, and I would answer the same way for methadone or Suboxone. There'll be patients that say, methadone or Suboxone was the thing that really helped me become abstinent from opioid use. And I feel well on it. It got me back to being a functional person, getting back to my job, getting back to my family, and I feel well on it. And from the practitioner side, it's sort of like, well, are there any adverse effects of the Suboxone or the methadone? Any reason why I'm worried health-wise for continuing these medications? And I think that you look at those two things and you have a good discussion with a patient. Obviously, I have these discussions more with patients on Suboxone, and some will tell me, I feel like I'm at a place where I don't want to be dependent on Suboxone anymore. I don't want to have to come to see you every month for this medication, and I'd like to try to be off of it. And I think that's very reasonable. And I would think that it's the same thing for methadone. But your point is very well taken. You can't just stop it, right? Because patients are going to feel terrible. They're going to withdraw. So if the decision is made to taper, it has to be a slow taper. And I could kind of tell you when we start talking about doses for Suboxone, I taper by like 2 milligrams every 1 to 2 weeks with a reassessment, either talking to the patient by phone or bringing them back in the office and seeing how they're feeling. And it's not a one-way street. If somebody starts to taper and they say, you know what, I don't feel well, I want to go back up, then again, it's all kind of patient-centered. Again, I'm not a methadone expert because I'm not licensed to prescribe it, but I've had patients tell me that when they've tapered on methadone, they do really well with the taper, but the hardest part of a methadone taper is when they get down to the end of it. When they get down to, 10 or 15 milligrams, it's really hard from a withdrawal standpoint to complete that taper. And often they really need some help in terms of adjunctive medications to control symptoms as they're tapering off. So I think my short answer for you is it's absolutely possible for patients to achieve remission and then taper off of these medications. And I think it needs to be a patient-centered sort of decision. And the risks of tapering off are relapse, right? And then I think you don't want to lose touch with patients because if they struggle with a relapse, restarting these medications is also an option. And I hope that answers your question. The other thing I'll say is that the literature that I've read is that the highest period of relapse risk is the first year. So I often don't necessarily have a lot of discussions, and I certainly don't push getting off of Suboxone within that first year because you really want to try to establish stability. And it's after that first year, if things are really stable, that we start to have those discussions. But that's just my personal practice.
We have several comments. However, I did want to ask a question by Vanessa as an internist. And I think you kind of led a little bit into this. As an internist, do you build up or go directly to buprenorphine treatment? Some outpatient MAT treatment providers will start with buildups.
Yeah. So usually I would go right to buprenorphine treatment, and I'll talk a little bit about how I do it as an internist, because usually people are actively using, and you can't start the Suboxone, the buprenorphine right away. So I'm going to go into this in my subsequent slides, but usually I prescribe a combination of different things to help with the symptoms of withdrawal. And then when it's appropriate, from a withdrawal standpoint, I will then initiate the buprenorphine. I will have slides in a little bit about that.
And then Anna also said methadone is good depending on the severity because at least on methadone you can monitor more closely and frequently.
Yep.
And Vanessa added in advantages of non-OTPs prescribing is less frequency of patient need to be seen as well as sometimes more cost effective for the patient.
Yeah. Thank you. Thank you. Those are, I think, great. And I have that in a table coming up here. So these are a few things. So methadone can be used for detoxification and maintenance. Its formulation is oral. And for detoxification, the kind of the normal range of dose is 20 to 40, and for maintenance, 80 to 120, although I've seen higher and lower doses for maintenance. Adverse effects, you can certainly overdose on methadone unintentionally, so you do worry about respiratory depression because it is a full opioid agonist, so we worry about oversedation. The other thing that we can see is prolonged QT interval on the EKG that can lead to cardiac arrhythmia. And that's why usually as part of my intake, I want to know a baseline EKG so I can see. And if the person has a prolonged QT to start with, that may give me a little bit of hesitancy about recommending methadone. Constipation, but that's all opioids. And there's some evidence for sexual dysfunction. And then, like you guys said, it is only available at the designated federally regulated opioid treatment site. So you can't get it, through your psychiatrist or through your primary care doctor. And a lot of patients will tell me, I don't like to go every day to the methadone clinic. I can't go every day because of my, job. And some people say that they don't like the stigma of having to go to a methadone clinic where they may, people kind of know why you're there. And some people have even told me that there can be triggers for use at a methadone clinic because there are people that are selling drugs in those vicinities. I'm not sure how true that is, but that's what patients have told me. But like you said, it's tried and true. It's an old medication. It's proven effective for opioid use disorder, and it's also for the self-pay patient who doesn't have medical insurance. It's definitely cheaper than buprenorphine. So those are some things that you take into account. Buprenorphine, like we said, is that partial agonist, so it's weaker. It can be used for detoxification. It can be used for maintenance. The normal formulations is under the tongue, although there are formulations where you can have a buprenorphine injection. I don't want to overspeak because that's not in my practice. I normally prescribe the sublingual. The dose varies from 2 milligrams of buprenorphine to 32, and the side effects are constipation because it's an opioid, other GI side effects, and because it's a partial agonist, as you can imagine, it's weaker, right? So the overdose potential is less because it's just not that potent, and it binds very tightly to the opioid receptors. So you can imagine there's a bit of a ceiling effect with buprenorphine, where you're going to have all of your opioid receptors saturated with this weaker opioid, and so the risk of overdose, while it's not zero, is going to be less than medications like methadone. And the trick, though, is starting it, because if you have a much more potent opiate in your system, like fentanyl, for instance, if you give buprenorphine before that fentanyl is out of your system, then what's going to happen is that you're going to bump that stronger opiate that has weaker binding affinity, and you're going to replace it with something much weaker, and you're going to precipitate withdrawal. So a person is going to feel really crappy, and they're not going to want to be on buprenorphine anymore. So you have to get the timing right as far as when you can start buprenorphine. Patients have to be in withdrawal before they can start the buprenorphine, and that can be tricky. And then I put the X here because that DEA waiver is no longer required, thankfully. And then finally, naltrexone is just an opioid antagonist, and you can use it for maintenance. You can give it oral, and you can give a 1-month injection. The doses range from 25 to 100 if you're giving it orally, or a different formulation, different dose IM. Some GI side effects, and then also precipitated withdrawal. If you give an antagonist to somebody who has opiate on board, you're going to precipitate withdrawal, and anybody can prescribe it. So those are some of the advantages and disadvantages of both. Now, what's the evidence, right? Like, we'd like to know that that what treatments we're giving is backed by evidence. So this is an old one in the New England Journal of Medicine from 2000. So they looked at levomethodil is sort of like a methadone-like medication. So I'll focus your attention to buprenorphine and methadone. And they looked at both of those for opioid dependence. And the main outcome of this study was that maintenance treatment with buprenorphine was as effective as methadone in reducing and supporting treatment retention. And again, I'll point out that in both groups, the percentage of patients with 12 or more opioid negative urine drug screens was only about 25% in both groups. So again, it's not this foolproof cure, but it does look like it helps. And in this study, methadone and buprenorphine seem to be as effective, equally effective. Now, this is a newer, oh, yes.
I'm so sorry to interrupt again. Rachel asked a question on the previous slide, I believe. Can that be why patients say Suboxone wasn't for me, maybe because the timing wasn't right?
Yes. I don't know if that's happened to you guys, but it happens to me a lot. It happens to me more in the hospital. I'll admit a patient who maybe say is coming in with a skin abscess, and you start to take your history and you start to realize they are suffering from an opioid use disorder. And you start to try to figure out, well, okay, what have you tried in the past? What's helped you to get into remission in the past? And you'll mention Suboxone. And I've had so many experiences where patients are like, oh, I never want to be on that again. I tried it once, a friend gave it to me, and it made me feel awful. I started to throw up and have diarrhea. And what has happened is that they still have opiate in their system and they start taking it too early. So I try to redirect patients to sort of tell them that it's not necessarily that the medication made you sick, it's that you just started taking it too early. And if they're willing to sort of be helped by us as providers to get them back on it, then we do it in a way that we make sure they're withdrawing already, and then we start it. So sometimes patients are totally turned off to Suboxone because they've had that experience. So yeah, thanks for that question. Please keep interrupting if there's stuff, because I'm not seeing the chat. This is a more recent study, and it looked at buprenorphine versus methadone for opioid use disorder, and it was a review of all prior studies. So it looked at 7 randomized controlled trials involving about 3,600 patients. And the conclusion was that methadone was actually associated with better retention. So patients stuck with methadone treatment programs more than Suboxone, but Buprenorphine-naloxone presented a more favorable safety profile. And that makes sense, right? We talked about, methadone being this more potent full agonist. So the risk potential, the unintentional overdose potential, the QT prolongation, the respiratory depression and sedation is higher with methadone. But it does look like, at least on this study, that methadone kind of won out to Suboxone in keeping patients in the program. And the authors of this study concluded that these findings highlight the need for individualized treatment decisions based on clinical context and patient-specific risks. And it also recommended future big, better studies so we can continue to learn more about this. So I try to have a good patient-centered discussion. I try not to push one versus the other. I tell patients that I'm more comfortable with Suboxone because it's what I am allowed to prescribe. So I just have more experience prescribing it, but that doesn't necessarily mean that Suboxone is better for them. And I try to just kind of go over the risks and benefits like we just did right now and try to help people make the right decision for themselves. Okay, so evaluating patients for Suboxone therapy. So this is kind of what we do in the hospital or in our clinic. So first, you want to make sure that you've established the diagnosis of opioid use disorder. And that goes back to the initial slide I showed you about the DSM-5 criteria. You just want to establish that a patient actually has opioid use disorder and then where it falls on the spectrum, mild, moderate, or severe. I always like to take a good medication history. What else are they taking, both prescribed and over the counter? And that helps me know that if there's going to be potentially any drug-drug interactions. I definitely want to take a good substance use history, not just opiate, but anything else. I go over, benzodiazepine, alcohol, cocaine, any other drug use. I just want to know a good, complete history. Even if those substances are in remission and somebody has used cocaine 10 years ago, I want to get it all out there so I can just really fully understand. Like was mentioned earlier in this talk, you really want to tackle psychiatric comorbidities, right? You're not going to be successful if you're not trying to address psychiatric comorbidities. And medical comorbidities is really important to know, right? It's going to be really important for us to know if somebody has, advanced COPD and they're, on home oxygen and they're at risk for, carbon dioxide retention. And now you're getting ready to start a sedating medication that could make that worse. So really important to get a good psychiatric and a good medical comorbidity history. I like to focus a lot on that first visit and subsequent visits about psychosocial. I like to ask, who are you living with? Who's your circle? Do the people in your life, are they using as well? Because it's tough, right? If the triggers for the use are going to be all around you every day because your spouse or significant other is struggling with a substance use disorder, it gives you a sense of what you might be up against. Prior substance use treatment, I really like to ask, what's the longest period of time that you were able to be drug-free? And then they say, well, 4 months. And then, I sort of say, well, great, that's hard to do. That's a long period of time. How did you do it? What allowed you to be drug-free for that period of time? And a person might say, well, I went to an inpatient program, or I was on Suboxone, or I was on methadone, right? I was incarcerated, right? You get all different kinds of answer, but you can use that to say, well, it sounds like methadone really helped you for 4 months. How happened that you left the methadone program? Might getting back on methadone be the right thing for you? So it's always really helpful to know what people have tried in the past. I like to kind of get a sense of how well patients have adhered to coming to their appointments, to taking their other medications. It just gives me a sense of, how adherent they might be to the treatment program that we're going to lay out. And then, of course, I always want to know, like, what resources do I have available for that patient and what resources they might have available. I'm primary care. I go and I work at my clinic 1 day a week. And when I'm starting patients on treatment, I will see them every week. But sometimes patients need more intensive treatment than that. Sometimes patients need 5-day-a-week treatment or 3-day-a-week treatment or inpatient treatment. And I have to know where my limitations are so that I can recommend if someone needs a higher or more intensive level of care, I have to know what's at my disposal that I can then offer. I need to know what my behavioral health community offices are in my area that I can recommend to my patients. So those are all the things that I sort of ask myself and I ask the patients when I'm meeting them for the first time. Okay, so when we decide we're going to start Suboxone, the term for starting Suboxone has been induction therapy. So because of what I said about the way that Suboxone or buprenorphine works, is that you want to measure objectively at least mild to moderate withdrawal before a patient is going to begin taking Suboxone. And you may use this in your practice. This is what we use in ours. We use something, it's a validated scoring tool called the Clinical Opioid Withdrawal Scale, COW score. And you want your patient to score at least 12 or 13. That indicates mild to moderate withdrawal. And that tells you that they're probably ready for their first dose. And I'm going to show you on the next slide. You could, if you go to Google, you could pull up this scale right away. And the text is very small, but I put on the side here the things that we measure. Heart rate, presence of sweating, presence of restlessness, pupil size, bone and joint aches, runny nose, GI upset, tremors, yawning, anxiety, and goosebumps, right? Those are all your common symptoms and signs of opiate withdrawal. So you get points for each of those things as far as how severe they are, right? And you add up those points and then you can classify mild, moderate, or moderately severe or severe. And you can get a sense that your patient would be ready for that first dose if that score is 12 or higher. So if you've decided that the patient is in withdrawal, normally what we'll do is we'll give a first dose. It's a low dose. You can give 2 milligrams or 4 milligrams, depending on what you read. The recommendations vary a little bit. but normally I'll give 4 milligrams as that first dose. And what you want to do, if the person takes that dose and then they feel much worse, they're starting to have worsening withdrawal, then what you know is they still have their opiate in their system. And it's probably not going to be wise to continue to give them more doses. You kind of pause it for a day and you go back the next day and you recalculate the COWS score. So you give the dose and then you reassess about an hour later. If they're not feeling worse, but they're continuing to have withdrawal symptoms, you can give a second dose of 4 milligrams, and then you can reassess about an hour later. And if they're not feeling worse, but they're still having withdrawal, you can give a third dose. Normally, the max dose for the first day is 12 milligrams. I tend not to go higher than that for the first day. But if a patient takes 4 milligrams or 8 milligrams and they feel much better, then you're great. You don't have to give 12 milligrams. The idea is to get them feeling better, to not be having withdrawal symptoms and to not be having craving. And while you're doing this, you can be giving other adjunctive medications for withdrawal symptoms. And that commonly are medications to help with anxiety. So I tend to use clonidine. Some people will use medications like hydroxyzine, and some will use benzodiazepines, although I'm always a little nervous about benzodiazepines because they can be sedating. There tends to be a lot of muscle and joint aches, so I'll try acetaminophen and ibuprofen, and then antidiarrheal agents like loperamide or I forget the brand name for loperamide, Imodium, and antiemetics like Zofran. So you give those medications at the same time to try to mitigate symptoms, and then you sort of titrate your dose. So if on day one the dose that really helped somebody was 8 milligrams, then you give that again the morning of day 2, and then you reassess to see if they might need more dosing than that. So if they're feeling unwell, craving withdrawal, then you can go up, and normally 16 milligrams is the goal day 2 dose. And then on day 3 and going forward, you're continuing to titrate the medication up to what's usually a max dose of 32 milligrams. Some people ask, well, do you have to bring a patient back to the office to do this every day? And I have to tell you, when I first started to do this in my clinic about 10 years ago, I didn't have a whole lot of experience. And so I was bringing patients back every day, which is not always easy for patients. The newer thinking is that you could probably do induction, not office-based, but with having phone calls with patients. So normally when I do my intake visit, I'll set a plan with patients and we'll say, okay, I'm going to prescribe you Suboxone. I'm going to say 4 milligram films up to 4 a day, but we're going to make a decision together about how much you're going to take. You're going to stop using your opiate, be it heroin or fentanyl. I'm going to prescribe you these other medications, clonidine, ibuprofen, Zofran, Imodium, and you're going to stop using your opiate, and we're going to talk every day by phone. I'm going to do this COWS score, and we're going to decide together when you're in enough withdrawal to be able to start this medication. And then we're going to have phone calls at least every day to try to get you on the right dose that's going to be for you. And then I will see them physically in the office every day. I definitely welcome any other thoughts about how other people do it, but that's normally how I go about it when patients are going to start this medication. If they're admitted to my care in the hospital, it's actually a lot easier, right? Because they're admitted to the hospital, they're there, and you can start this medication and you can monitor them obviously a lot more closely. But that's how I would do it in the outpatient setting. Okay, so for methadone, again, I cannot prescribe methadone for methadone maintenance in the outpatient setting, but if a patient gets admitted to the hospital and they are withdrawing from their opiate and they want to, they don't want to be sick, then you can give methadone in the hospital to mitigate withdrawal. And normally that would be giving about 10 milligrams to start and monitoring for oversedation and increasing by 10 milligrams about every 8 hours for usually a max dose of 40 milligrams. And I tend not to go higher than that. But again, the goal is to just try to get people feeling better so that they don't leave the hospital against medical advice and they stay for their treatment. So you can give methadone in the hospital. And then again, these are these adjunctive medications. Again, I tend to not use benzodiazepines, but some people do. But ibuprofen, antidiarrheal, antiemetic, and sometimes you can give sleep medications. I tend to try to stay away from sedating sleep medications like Zolpidem, which is Ambien. But you want to get patients feeling comfortable because from what patients have told me, it's a, pretty bad feeling. And if they feel terrible, they're gonna stop the treatment program and they're gonna start using again. This is just a slide about what clonidine does. It reduces the sympathetic nervous system response. So you really get help with sweating, hot and cold flashes, restlessness. You just have to be careful because clonidine is a heart rate and blood pressure lowering medication. So you have to watch out for hypotension and bradycardia. So if the patient is already having those things, you may not start clonidine. Okay, and then this is sort of a summary. So we really care about trying to link hospitalized patients up with care and not forget about their opioid use disorder when they're in the hospital. So we try to assess patients for opioid use disorder. We try to provide opioid agonist medication to prevent or treat withdrawal like methadone or buprenorphine. We assess patients' readiness for an interest in medications for opioid use disorder treatment. And we really try to link our patients up with outpatient treatment so that when they leave the hospital, they have a medication if they need it, or they have a plan to get linked up with care. I think it's the hospitalized patient it's a unique opportunity to try to link people up with care. Special considerations that you might see. A lot of our patients have pain, sometimes chronic pain, like chronic lower back pain or knee pain. And some patients are going to have acute pain for all the reasons that you or me might get acute pain. You break a bone, you get acute appendicitis, you have a scheduled surgery, and you have postoperative pain, right? Their patients are just like anyone else. So how do we deal with that? So the main thing is that patients with opioid use disorder often have chronic pain. Suboxone has a pain relieving effect, but it's often not as potent as other opioids, right? And often we need to seek a non-opioid pain regimen for chronic pain. So a lot of what I do in my practice is if a patient has pain, I try to think about non-opioid medications that might be able to help. So for instance, if someone has neuropathy or nerve pain, I might try a medication like gabapentin, or the brand name is Neurontin, to try to get at that pain without having to prescribe an opioid. And patients on Suboxone with acute pain should not be denied the pain management that we would offer other people. So if someone comes in to your care and they're on Suboxone and they're having acute pain or they're having a surgery with pain afterwards, it's okay to prescribe what we normally would prescribe. Maybe it's going to be Dilaudid or oxycodone. And the idea is to keep people on their Suboxone because they need to be on it. And you can give short-acting opioids on top of that. But you may need to give a little bit of higher doses than usual because remember, buprenorphine binds very tightly to the receptors. So the whole point is don't deny people pain management if they need it. Sometimes people ask about pregnancy. So how do you treat a pregnant woman with an opioid use disorder? So the consensus from the obstetric societies is that opioid agonist pharmacotherapy, whether it's methadone or buprenorphine, is recommended. And it's preferable to medically supervised withdrawal because withdrawal is associated with high relapse rates, and that can lead to worsening outcomes, both in mom and in baby. Patients that have HIV, the only point I want to make is that there are potential drug-drug interactions with buprenorphine and antiretroviral therapy. So if I have a patient with HIV that I'm starting on buprenorphine, I will either talk to their ID physician or call their pharmacy just to make sure that I'm not going to be giving them something that's going to result in an interaction. If your patient has liver disease, buprenorphine is not contraindicated unless there's significant elevation of your liver enzymes. And so when I'm thinking about a patient and wanting to put them on Suboxone, I will get liver function tests or LFTs to begin with, and then periodically monitor liver function testing. And then I always test and immunize against hepatitis B and hepatitis A, and I check HIV testing as well at the onset of therapy. And I think we've said this already, but untreated or inadequately treated psychiatric disorders can interfere with effective treatment of any substance use disorders. And so office-based treatment with buprenorphine or methadone must coexist with addressing psychiatric disorders. And I think it can't be said enough. Okay. And then very important is preventing overdose deaths. So here's some data for you. Patients presenting to the emergency department who survive an opioid overdose, their 1-year mortality after they survive that overdose is about 5.5%. That's not a small number. And about 20% of those patients will die in the first month of that after that index ED visit. So for patients that survive an opioid overdose, you want to see if you can get them into therapy as quickly as possible. And we know that when we do initiate therapy, it's associated with decreased mortality. And we never want to forget, and I never want to forget, to prescribe intranasal naloxone or Narcan, and educating patients and their loved ones on how to give it. And God forbid somebody overdoses, they can give it, just as a spray in the nose, because we know that this reduces overdose deaths. And the good news is that just a couple of years ago, the FDA approved over-the-counter naloxone nasal spray. So you don't have to have a prescription, although I do send prescriptions to the pharmacy. But a loved one of a patient or a patient can go to Walgreens or CVS, and they could actually buy Narcan to have on them. And I think it's just a really important medication to know about and to have for anyone that's on an opioid. Okay, so that concludes the opioid use disorder and the medications for opioid use disorder. I'm going to move on way more briefly to alcohol use and cocaine use. And I wonder, before I do that, are there any questions or comments about anything we just talked about? Okay, no problem. And again, if you think of something, just put it in that chat. So this is a little bit busy, but really, when you have somebody that's using alcohol, it's sort of a continuum. Alcohol is, in our society, it's legal, it's easy to get, and most people, not most, but many people drink to some extent. So you want to screen for at-risk use or alcohol use disorder. So it's broken down into lower risk alcohol use, and that's drinking in moderation. And we've defined that as adults consuming less than or equal to 2 drinks per day in men, or 1 or less drinks a day in women. And then you have unhealthy alcohol use. And that's broken down into at-risk alcohol use and of course, alcohol use disorder, right? And you can look at the slide and you can see sort of it's broken down into the amount of drinking that people do per day. And it's a little bit different in men and women. But alcohol use disorder is really the same criteria that I shared through DSM-5 for the opiate use disorder. Tolerance, impaired control, social implications. It's the same. And again, in the same way, we break it down into mild, moderate, or severe. So we classify alcohol use disorder the exact same way as we do opioid use disorder. So evidence-based pharmacotherapy for alcohol use disorder. So I want to share with you guys the 3 FDA approved medications that we have at our disposal for alcohol use disorder. So one is naltrexone. And if you remember, it's also approved for opioid use disorder. So it's an opioid receptor antagonist, but it also has been shown to reduce the rewarding effects of alcohol consumption. And I can tell you in my practice, that's the one that I prescribe the most and I'm most comfortable using. You could either give it as an oral formulation or an intramuscular injection. The second one is acamprosate. It modulates glutamate transmission, and its primary role is in maintenance of abstinence. So say someone who's gone through alcohol rehab program, and then they're maintained on acamprosate. I can tell you from my experience, the things that limit the use of acamprosate is adherence. It's a tough medication to take because it is 2 pills 3 times a day. And I'm not sure if I'd be able to do that. That's hard to do. And the other thing that limits its use is there's not a small amount of GI side effects. And some patients tell you they just don't feel well on it. And the third medication is disulfiram. And its mechanism is it inhibits aldehyde dehydrogenase. So you have acetaldehyde accumulation, and you literally feel awful if you drink. So people will get headache, flushing, nausea, and vomiting. So it's sort of like a deterrent, because if people are taking disulfiram, they know that if they drink, they're going to feel terrible. To me, that's probably the least commonly used, because patients, they don't want to take it. So I commonly mostly use naltrexone. And this is just a breakdown of the doses, the mechanism, like I said, and then the adverse effects. Obviously, naltrexone, we can't use it if somebody is also on an opioid. So if you have somebody on methadone, or if you have somebody on buprenorphine, then you can't give naltrexone, because you're going to make them withdraw. And we also avoid it if someone has advanced cirrhosis. And like I said, acamprosate, the adherence to it could be challenging. Off-label use, these are not FDA-approved medications, but some people off-label would use topiramate, baclofen, and gabapentin. I think out of all three of those, I tend to use gabapentin the most, because sometimes there's another reason to use gabapentin. Alcohol use disorder is associated with alcohol neuropathy. So some patients have neuropathic pain, and I find that it can be used for that. And sometimes when patients have a lot of anxiety, gabapentin kind of off-label can be used for that. So I don't really use topiramate or baclofen. Maybe some of you do. Gabapentin I might try if I have another reason to give it. And then, of course, I think it's really important to know that when you're giving a medication for alcohol use or any substance use disorder, that what's been shown is that medication plus cognitive behavioral therapy has been shown to be better than either used alone. And, you know, cognitive behavioral therapy, some people have it at their disposal at a, maybe at your site or a behavioral therapy site. I find that it's not always the easiest thing to link patients up to. But what I've learned over the years is that there's a lot of good resources online. There's some free cognitive behavioral therapy sites, and there are some that are, you have to pay for them. But you can sort of do your own search and see what's out there. And cognitive behavioral therapy can be quite effective, particularly when used in conjunction with medication. And then briefly, cocaine use disorder, which I find in my practice to be very challenging. The prevalence is rising over the last 10 plus years. Cocaine is the second leading cause of overdose death. Opioids are the first. And it's, it's a scourge in the community. And the problem is that there's no FDA approved medication to treat cocaine use disorder. There's no methadone or Suboxone equivalent for cocaine use disorder. Some studies are being done looking at medications like other stimulants, like amphetamine or modafinil, topiramate, disulfiram, but none of these are FDA approved, at least yet. So we struggle with knowing what to do to help people with cocaine use disorder, other than trying to address psychiatric illness and trying to do cognitive behavioral therapy. So that's kind of what I do with patients that are struggling with cocaine use disorder. And I try to stay up to date on what new drugs might be getting approved. Finally, I think we have another 5 minutes or so. I just wanted to talk about harm reduction, because I think that it's so much of what we do without even naming it. So I wanted to know, and you can put this in the chat, how would you define harm reduction? And what are some ways that you might be practicing harm reduction in not only in your care of patients, but even in your own life or with your children or your loved ones? Just some examples of harm reduction in our everyday practice in our everyday life. Just, 30 seconds to kind of put something in the chat if you want to. I'll give maybe 10 or 15 more seconds, and if there's nothing in the chat, I'll just move on with what I have to share. Okay, so I'm going to show you how harm reduction can be defined. So harm reduction refers to interventions aimed at reducing the negative effects related to substance use or other potentially harmful behaviors. Harm reduction does not condone or condemn substance use, and a clinician who practices harm reduction discusses the harms of substance use and identifies strategies to reduce associated harms, right? So it's not like someone who comes, to a needle exchange program. There are people there that are going to discuss with them how harmful intravenous drug use is and try to help them strategize about ways that they could achieve remission, but then tries to help them mitigate the risk of their use, right? That's kind of an example there. And then I just put some pictures of things that I thought are really common harm reduction in our lives, right? Seat belts, like, when you drive a car, you're potentially engaging in a risky behavior, and we put on a seat belt to reduce that. Promoting or giving out condoms, right, to protect against STIs. Promoting the HPV vaccine for cervical cancer, the nicotine patch for smoking cessation, designated drivers for mitigation of at-risk driving when someone's using, and then pre-exposure and post-exposure prophylaxis for HIV. To me, and there may be way more examples that you guys could think of, but these are some everyday life and everyday practice of medicine harm reduction strategies that we employ. And then specifically when it comes to the treatment of opiate use disorder, clean needle sites. And then of course, these medications that we've been talking about, Suboxone, methadone, Narcan, right? Prescribing Narcan. And then I don't know if you guys know what this picture is here with these little cubicles. I don't think, to my knowledge, we have any in the state of Connecticut, but some states actually have, I think they're called like safe usage sites, where people can actually go to a place and use, inject or take their drug and have it sort of monitored, where there's, clean, needles, receptacles, and people that are on site that are CPR certified and have Narcan if, God forbid, there's an overdose. And I don't know how I feel about that, to be honest. There's controversy there, and you might have your own feelings about that. But those are things that are out there that I think it's important to know about, and it's important to kind of think about, your own approach and your own sort of where you fall in the continuum of how you're employing harm reduction in your own practice as a healthcare professional. And then finally, I think this is my last slide. I always try to remember for myself, and when I'm teaching residents, that words really do matter, and how we say it, what we say, it really does make a difference. So there is stigmatizing language that sometimes I use and I'm not even aware of it. So I try to make myself more aware. Instead of saying addict or alcoholic or abuser or junkie or drunk, it's a person with a substance use disorder. Abuse would be use or misuse or risky use. A lot of times patients will use the word clean, like, I know I'm not clean, doc, or I know my urine's going to be dirty. And I try to say, well, it's not really like that. It's, your urine is with an abnormal finding or an unexpected finding, or you're having, active use, or you're in remission or you're abstinent, rather than using clean or dirty, because there's like a stigma associated with that. And then, we say things like treatment for medication for addiction, medication for opioid use disorder. So it just, to me, I try to always check myself to make sure that the language that I'm using is going to, be appropriate for the patient and entrust them to the care that they're receiving. Because I think, in my experience, a lot of patients have developed a bit of distrust for the healthcare because they perceive that they've been ostracized or stigmatized. And if you want to be successful in a treatment plan, people have to trust you. So with that, I just want to recap. So this particular patient, what we ended up doing was I prescribed Suboxone, and I prescribed these other medications for withdrawal symptoms. We talked every day, and at about 72 hours after his last use of fentanyl, he was in enough withdrawal where he started Suboxone, and he started just like we talked about. 4 milligrams. He reassessed how he felt. He took 8 milligrams on the first day, about 12 milligrams on the second day. and then he up titrated from there. And he's currently on 3 films or 24 milligrams of buprenorphine every day. And he is still struggling with some use, although his use is much, much reduced. And we're still continuing to work on a plan to get him into full remission. And that has to do with trying to link him up with behavioral health care. So that's sort of where we're at. And it's an ongoing plan of care for him. I want to end with some, I think, really positive news. This news just came out that adults, older adults, 65 or older, medications for opioid use disorder, or MOUD, has increased from about 5% to 15% over the last 5 years. And we think it might be a new Medicare policy that covers methadone, and people are having increased access to service. So between 2017 and 2023, the percent of opioid treatment programs like yours that offer all 3 FDA-approved meds, which is methadone, buprenorphine, and naltrexone, has increased from 33% to 45%. So I see that as a positive. And then finally, new provisional data that were released by the CDC just last month predicts that there's a 24% decline in drug overdose deaths in the United States for the 12 months ending in September 2024 compared to the previous year. About 87,000 drug overdose deaths from 2023 to 2024. And that's the fewest overdose deaths in any 12-month period since June of 2020. So because of, your efforts that you're making, and, hopefully some of the work that's being done in the primary care community, and knowledge and access to care, hopefully we're going to continue to see a decline. That's my hope. So I hope, again, that we achieve the learning objectives for the hour. And I want to thank everybody who joined and participated. And certainly any questions that you might have, I'd be happy to remain and take any questions.
While we're waiting to see if anybody has any questions, I just wanted to read a comment by Maya saying, I'd say harm reduction is anything that lessens their risk, whether that is drinking less, using less, delaying use, or things like using clean needles, being monitored while using, etc. As for self-care, harm reduction, I encourage with my clients, whether using or sober, are things like evaluating eating habits, hydration, hygiene, or treating their mental health if they don't feel ready to address the substance use.
I love that. Thank you so much for sharing that with everybody.
And I'm not seeing anything else coming through right yet.
No problem.
We'll give it a few more seconds.
And I think I'm perfectly okay if you'd want to share my email address with everybody.
Perfect.
I consider we're all partners in the care of our community. So I'd be happy to engage in conversations, and I'm sure I'd have questions for you guys too. It's I just really appreciate the opportunity to join you guys today.
That's awesome. So I think we are probably good. I'm not seeing any questions pop up. And you could always raise your hand and we'll pick up on that also, but okay, well, thank you everyone. Thank you, Dr. Scholero, for joining us today and for enlightening us and giving us some insight from an internist point of view.
Thank
Certainly
you for having
appreciate
me.
your time and your knowledge.
Have a good day, everybody.
Thank
Take
you.
care.
Take care.